Good morning. Today we're discussing pulmonary hypertension. The definition of pulmonary hypertension has evolved. It uses mean pulmonary pressure to diagnose it. A mean pulmonary pressure of greater than 20 millimeters mercury on right heart catheterization is the definition. Pulmonary hypertension can be thought of as a final common pathway. Different disease conditions increase pulmonary vascular resistance, causing the pressure to go up. Inevitably, as pulmonary hypertension worsens, right heart failure ensues as right heart hypertrophy initially, followed by dilatation failure. Pulmonary hypertension can be thought of as precapillary or postcapillary. In precapillary pulmonary hypertension, the primary issue is in the pulmonary arteries. The mean PA pressure is greater than 20. Pulmonary capillary wedge pressure is less than 15. Pulmonary vascular resistance is higher. Initially, PVR of 3 or 4 was used. Nowadays, PVR of 2 is used. In postcapillary pulmonary hypertension, the issue is back pressure from the left heart. Mean PA pressure is greater than 20. Wedge pressure is greater than 15. Pulmonary vascular resistance is less than 2. We use the WHO classification as a roadmap for etiology specific management. Group 1 pulmonary hypertension is pulmonary arterial hypertension. Group 2 is pulmonary hypertension due to left heart disease. Group 3 is pulmonary hypertension due to lung disease and or hypoxia. Group 4 is pulmonary hypertension due to obstruction such as pulmonary embolism. Group 5 is unclear or multifactorial mechanisms such as lupus, etc. Moving on to the common cause of pulmonary hypertension, left heart disease, also known as group 2. The cause is passive back pressure from left ventricular dysfunction or valvular disease. The profile is consistent with an elevated pulmonary capillary wedge pressure. Therapy is to treat the underlying cardiac condition. Diuresis for heart failure, fix the valve problem, etc. It is critical not to use PAH specific pulmonary vasodilators as they can increase mortality. For pulmonary arterial hypertension, this is a disease of proliferation and vasoconstriction. The pathophysiology is vasculopathy of the distal pulmonary arteries characterized by endothelial and smooth muscle cell proliferation. The management goal is to maintain a low risk status as assessed by using the REVEAL score. We'll go into this in a little bit. The 3 targeted therapeutic pathways: endothelin receptor antagonists such as ambisartan, bosentan, macitentan; nitric oxide pathways such as sildenafil, tadalafil, rycoguat; prostacyclin pathways such as epoprostenol, trepoprostenol, selexipag. All of these work at the pulmonary artery. Group 4, CTEPH, chronic thromboembolic pulmonary hypertension, is a disease of organized thrombi. Basically, the blood clots plug up the pipes, increasing the resistance, and then there's fibrotic material mechanically obstructing the pulmonary arteries. The diagnostic key is a VQ scan, which is a preferred screening test. A normal scan effectively rules out CTEPH with high sensitivity and specificity. You confirm it by using high-quality pulmonary CT angiography, which shows features like webs, bands, abrupt vessel termination. The definitive treatment is pulmonary endarterectomy. It's a highly specialized operation. It can be curative. There are very few centers in the world that perform this successfully. So patients should be referred to a high volume center. For inoperable CTEPH and other pulmonary hypertension groups, we use rycoguat. For group 3 lung disease, the treatment is focused on treating the underlying condition, optimizing oxygen delivery for COPD or interstitial lung disease. For group 5 or multifactorial, treatment is directed at the primary systemic disorder such as sarcoidosis, myeloproliferative disorders, etc. So the clinical suspicion symptoms are consistent with shortness of breath, dizziness, palpitation, swelling of the feet, syncope. So you have to have a high index of suspicion. Initial non-invasive assessment is echocardiogram. Then you screen for the key etiology, the VQ scan, pulmonary function tests, CTA, serological tests. Gold standard is the right heart catheterization to confirm a mean PA pressure of greater than 20 and assess the wedge pressure. Targeted management depends on the underlying etiology. The goal is to achieve and maintain a low risk reveal profile. Reveal profile is a multi parameter assessment. For example, a low risk patient with less than 5% 1 year mortality would have a functional class 1 or 2, 6-minute walk distance greater than 440 meters, BNP levels would be low, and the echo would show normal or near normal RA size and pressure. Intermediate risk 5 to 20%, class 3, 6-minute walk distance 165 to 440, BNP levels intermediate, echo shows RA enlargement and elevated RA pressures. High risk, class 4, 6-minute walk distance less than 165, BNP or pro-BNP levels high, such as more than 180, RA measurements are enlarged on echo, RA pressure greater than 20, and a low cardiac index. It should be remembered that if the RV fails, the PA pressure may not be high. Moving on to RV failure, chronic pressures overload forces the RV through a sequence of hypertrophy, dilatation, contractile failure, leading to a low cardiac output state. When the RV enters a low cardiac output state, the PA pressure may not be as elevated. Clinical manifestations include worsening peripheral edema, ascites, enlargement of the liver, syncope. Patients may have atrial arrhythmias, flutter, fibrillation, hemoptysis from ruptured bronchial arteries, compression of adjacent structures such as recurrent laryngeal nerve, also called Ortner syndrome. Optimal care requires a specialized multidisciplinary team. Referral to an expert center should be considered. There should be a pulmonologist or a cardiologist who is a pulmonary hypertension expert surgeon for thromboembolic pulmonary hypertension, radiologist for diagnosing CTEPH, rheumatologist for managing rheumatological disorders, pharmacist and a specialist nurse coordinator. Core principles, you got to think beyond the pressure. It is a clue, but the question asked is, why does a patient have elevated pulmonary pressures? A right heart cath is needed for making the diagnosis. It measures mean PA pressures and pulmonary vascular resistance and differentiates between pre and post capillary. Treatment classification depends on the WHO group and is highly specific to the group. Standard of care really is referral to an expert center with high volume and experience, with multimodal therapeutic capability and proven outcomes. When patients have high Wood units, so the Wood unit basically is you subtract from the mean PA pressure the pulmonary capillary wedge pressure and divide by the cardiac output. To go from standard units to Wood units, divide the number by 80. If the Wood units are greater than 16 or approach 20, patient has a very high mortality. A Wood unit of 5 after surgery is a sign of poor prognosis. So it assesses how plugged up the pulmonary artery is. Thank you for listening. More to follow.